Hi, my name is Steve Cheung. I'm one of the pathologists at the Orlando Health. And I'll come back and talk a little bit about Orlando Health in a few minutes. I just want to spend a few minutes talking about our experience with in-house NGS. And let me go to this disclaimer. You can read that for a minute or two. So Orlando Health, as the name, will indicate, we're located on mainly in Orlando. However, our 15 hospital system recently we acquired 4 hospitals in Puerto Rico as well. So I don't know if the name's going to change or not, but it's still mainly Orlando Health, in Orlando. We do have one hospital that's down in Tampa as well. So we do, mainly in the Central Florida region. We also have 9 freestanding EDs, and we have over 3,500 beds, and over 4,750 physicians. We basically have all the medical specialties cover over 100 of them. So it's pretty, extensive, the health system that covers lots of different procedures and subspecialties. So we actually had a quite, somewhat of a, intermediate history with in-house NGS. We actually started it back in 2014. We started planning on having an in-house NGS. And in 2016, we actually did have in-house NGS running at that point. And one of the main reasons for that is to decrease the turnaround times of the results that we were getting from the outside vendors. And obviously, it was a limited panel at the time, and it was mainly used for lung melanoma, gastrointestinal tumor, and breast tumors. And at the peak in 2000, I guess right before 2020, we had almost 230 cases. However, as everyone are aware, the kind of COVID happened, around that time too. So we actually had to shut down the NGS program because all the techs had to be moved over to for COVID. And even up to this day, we still do that. A little bit about our group. We're 14 pathologists. We're 1 molecular pathologist and 3 MD PhDs in our department. We are a private group that contracts with the hospital system. So after, I guess COVID is still here, but post, the really uncertain times, we decided that we do want to bring back the in-house NGS because our turnaround time, we noticed for lots of the NGS results were coming back later and later, I think up to 4 or 5 weeks for most cases. So in 2022, we decided to, bring back NGS in-house, and we, decided to use a limited DNA and RNA panel in a newer semi-automated NGS platform. And we finally went live in February 2023. And I'll come back to, how our experience is since February 2023. So our strategy was, because COVID was still happening with our molecular techs, we're still performing lots of testing for infectious disease. We decided we want to go really slow and want to figure out the workflow before we went, I guess more broadly go live. We had 4 molecular techs. Now we're down to 3, and we decided that only some of the oncologists would be able to order the in-house NGS testing, so that we would not be overwhelmed. And we also decided to focus on lung, non-small cell carcinoma, mainly on adenocarcinoma, because the panel we're using, the DNA and the RNA panel, was really informative for that particular tumor. The other thing that we decided to limit on was how many pathologists could pick the blocks. We also noticed that many times we have pathologists looking at slides and sending blogs or unstained slides to outside facilities where we get lots of QNS, so that they were insufficient for further testing. So we decided to train just the 3 of us, and we were pretty stringent on which one we can pick or not pick, or how many slides or how many unstained slides are needed for the testing. But besides the pathologists, we also limit on the staffing because the staffing is also very important. We limited a few of the staff who actually can get the NGS set up. So the multiple step. One is the ordering step. The other step is from the block, going to the histology lab for them to cut unstained slide or scrolls, and then from the histology lab to the molecular lab to perform the test. And that way is actually much cleaner, and there was less chance of error for the whole process. Let me spend a couple minutes on the Rasti team. And first of all, they're wonderful. They're really, they're very excited to be a partner with us. And I think that's the key word. They are partners with us in this endeavor. And so there's going to be ups and downs when you bring an in-house NGS in. So you kind of need the clinicians to understand and to be with you the whole process. We have 4 thoracic surgeons and we're 2 interventional pulmonologists. There were 396 lung excision in 2023, and there were over 1,000, EBUSs, endobronchial ultrasound biopsies, and all with plus or minus the navigational bronchoscopy, which they were able to basically go into the lung to perform biopsy at the nodule itself. We diagnosed over 750 new lung cancer cases in 2023. So we'll go over some of our experience. Again, this is pretty limited because like I said, we want to go slow to make sure things were working. We had 285 orders for our in-house NGS. And among them, the 16 samples were deemed QNS before we sent to molecular labs. So again, it's those 3 pathologists, me and 2 other pathologists, deciding that these were, QNS. So it's not worth doing them, from the beginning. And so which left us 269 patient samples with extracting sequences. And which amazingly, actually only 2 of those samples were deemed QNS after we did extractions. And everything that was deemed sufficient for after the extractions were all worked in the sequencing. So like I said, we were trying to small cell carcinoma, specifically adenocarcinoma. So it's not surprising that almost 59% of the samples we end up sequencing were lung adenocarcinoma. About 5% was lung squamous cell carcinoma, around 8% was melanoma. So for the lung adenocarcinoma, we went back for the whole year and we looked at the mutations that were detected to see how that's, how comparable it is to the, other literature or other data from other institutions. So we found KRAS mutation in 35.8%, which is a little bit high. I think the literature suggests 10 to 30%. We detected EGF mutations at a rate of 20.3%. In the literature, I think for Europeans patients, that 10 to 20% is pretty normal. And for Asians, it's actually greater than 50%. For the ALK mutations, we picked up 2.7% of the time. The literature suggests 2 to 7%. The MET exon 14 skip, we were able to pick up 3.4%, which is actually pretty dead on. It's between 3 to 4% in most literature. Same thing with ROS, RET mutation, and then PIK3CA mutation as well. So it seems like we're really doing a pretty decent job at picking up sort of the expected frequency for these mutations for lung adenocarcinoma. So one of the things that we decided to do, well, we meaning actually the oncologist team wanted to do was a QI project to see if the in-house NGS actually really improve the turnaround time. So they looked at it a little bit differently. They actually looked at the only for stage 4 patients, stage 4 cancer patient, lung cancer patients. And they looked at the time from the collection time to the time of the result, because it's a lot easier for them to know when the sample was collected and when the result was resulted. So they look at that. So it's not quite a turnaround time in the laboratory sense, because for us, it's usually when we receive the order till the time we result the NGS results. So what they did was they compare, I think June 2021 to May 2022. That was before we have the go live in-house NGS. They found 49 patients that fit that criteria. And what they found was that the average from the collection time to the time of resulting was around 31 days, and the median was 29 days. As you can imagine, 29 days is a month. And like I mentioned, that's the reason why we decided to go back and brought in-house NGS. After the go live, just actually in a, I think 2, 3 months between February 2023 to May 2023, we found 18 patients that fits the criteria. And for the collection time of the results, again, from the time it was collected to the time that we result the NGS results, the average was almost 14 days, and the median time was 7 days, which is the p-value is significant between those differences. And interestingly, a lot of oncologists doing the plasma testing, and they found that the turnaround time for both, because they all sent out anyway. They found that 13 of those patients back in 2021, 2022, 13 of them were sent out for the plasma testing, and those turnaround time were 13 days. And for the in-house, the one that we just, the more recent one from February 2023 to May 2023, the average turnaround time was 10 days. So that is not a huge significance in the plasma testing, and that number is not significant. So we're very excited, and obviously the oncology team was very excited. And what this means actually is that they can basically have these results, right when they see the patient, the first time they see the patient after the procedure, so they can actually plan very accurately what the regimens or the chemotherapy or any other therapy that they can use for that patient in the first visits. And we have continued that, we continue to look at the turnaround times, and we found that the average turnaround time is 9.5 days from the date of receipt to the date of the results. Again, this is a laboratory way of looking at the turnaround time. The median number is 9 days. So most of the time, within less than 10 days, we can get the results out. And I hate to say most of the time is because the pathologists like myself and the other pathologists were taking a little bit longer to look at these data. So the data were probably out 3 or 4 days before that. Just took us a little bit longer to look through them. And the range of the resulting is from 2 to 14 days. And we actually had quite a few of those 2 days where we were able to get the mutations for melanoma patients that needed, the clinicians wanted to know if there were BRAF or other actionable mutations. So they were very pleasantly surprised that we could get these results out so quickly. In the future, we definitely want to continue to expand this in-house services to adding more different panels, for different type of tumor and malignancies. We'll have to scale that up, and we will obviously continue to monitor our performances and metrics. And we think that the workflow can always be improved, so we're still working on that. And I know this is a little bit short, and I want to leave lots of time for any questions.